Welcome to Clinical Tools Library, evidence-based scales and questionnaires designed to support healthcare professionals in practice. The Conners rating scales assess behavioral, emotional, and cognitive symptoms commonly associated with attention deficit hyperactivity disorder and other neurodevelopmental conditions in children and adolescents. These scales provide standardized measures of inattention, hyperactivity, impulsivity, and oppositional behaviors based on reports from parents, teachers, or clinicians. The main purpose is to facilitate the identification, diagnosis, and monitoring of attention deficit hyperactivity disorder symptoms over time. The scales aid in evaluating treatment effectiveness and guiding clinical decision-making. They have demonstrated high reliability and validity in diverse populations. The Conners rating scales are indicated primarily for children and adolescents aged 6 to 18 years who are being evaluated for attention deficit hyperactivity disorder and related behavioral problems. They are most useful in clinical contexts involving the assessment of symptoms of inattention, hyperactivity, impulsivity, and oppositional behaviors. These scales facilitate the collection of standardized information from multiple informants, including parents and teachers, enhancing diagnostic accuracy. The tool supports monitoring treatment response and tracking symptom changes over time within both outpatient and school-based settings. The Conners rating scales begin with selecting the appropriate version based on the respondent, such as parent, teacher, or self-report for the adolescent. The scale contains 47 items that assess symptoms related to attention deficit hyperactivity disorder and related behavioral concerns. Each item is presented as a statement describing specific behaviors. Respondents rate the frequency of these behaviors over the past month using a 4-point Likert scale ranging from 0 for not at all to 3 for very much. After completion, raw scores are calculated for various subscales, including inattention, hyperactivity, impulsivity, learning problems, and oppositional behavior. These raw scores are then converted into T-scores using normative data based on age and gender. T-scores from 66 to 79 indicate moderate elevation, suggesting the presence of clinically relevant symptoms. Scores above 79 represent significant elevation and may require further clinical assessment. Scores below 65 are generally considered within the typical range. Interpretation should consider the pattern of elevations across subscales rather than isolated scores to guide diagnostic or treatment decisions. Sensitivity refers to the ability of a test to correctly identify individuals who have a condition, indicating the proportion of true positives. Specificity indicates the test's capacity to correctly identify individuals who do not have the condition, representing the proportion of true negatives. Studies evaluating Conners rating scales have reported sensitivity values ranging from approximately 0.70 to 0.90, depending on the sample and diagnostic criteria used. Specificity values have been observed between 0.75 and 0.95. For example, if a clinician uses Conners rating scales to assess a child suspected of attention deficit hyperactivity disorder, a sensitivity of 0.80 implies that 80% of children with the disorder will be correctly identified. Conversely, a specificity of 0.85 indicates that 85% of children without the disorder will be correctly classified as not having it. These metrics underscore the scale's general effectiveness in distinguishing affected individuals, but also highlight the potential for false positives and false negatives in clinical practice. The Conners rating scales were developed in the early 1970s by Keith Conners to provide a standardized method for assessing behavioral problems primarily associated with attention deficit hyperactivity disorder and related conditions in children. Since their inception, extensive research has been conducted to validate these scales across various populations and settings. Psychometric analyses have consistently demonstrated strong internal consistency, with Cronbach's alpha values frequently reported above 0.9, indicating high reliability. Test-retest reliability studies have shown stability of scores over periods ranging from several weeks to months, supporting their temporal consistency. Construct validity has been supported through factor analyses that confirm the scale's dimensional structure aligns with theoretical constructs of hyperactivity, inattention, and impulsivity. Convergent validity has been established by significant correlations between the Conners scales and other established measures of behavioral and attentional problems, such as the Child Behavior Checklist and the Attention Deficit Disorders Evaluation Scale. Furthermore, normative data collected from large, diverse samples have enabled the development of well-calibrated percentile ranks and clinical cutoff scores that facilitate the identification of clinically significant symptomatology. Studies by Conners and colleagues, as well as subsequent research groups, have also examined the scale's sensitivity and specificity in differentiating attention deficit hyperactivity disorder from other psychiatric conditions, with reported values often exceeding 0.8, underscoring their practical utility in clinical diagnostic processes. Thank you for watching. For complete information and official PDF resources, visit clinicaltoolslibrary.com or check the link in the description below. And don't forget to like and subscribe for more clinical insights.